Anjali, can you mute Kshiti's one of the video?
We are live now, doctor.
Yeah. So, good evening, everyone. Welcome you all to the fourth episode of season 2 of Retina Surgical War. So, this was a unique concept which was started last year as for the first season, and then it went into grand finale in the YOSI Con. So, this year also we are planning the same 6 episodes, followed by grand finale in the YOSI Con in New Delhi. So, in every episode, we have three eminent speakers who present their video for 5 minutes, and then followed by panel judgment with the marks, and then there will be a online voting for the same. So today we have very good speakers. First one to go is Dr. Priyanka Channa, who is the Senior Retina Fellow in Retina Institute of Kashi at ASG Varanasi. Then second we have Dr. Srishti from AEC PGIMR Chandigarh. And third is Dr. Kshitij Rayajada. In the panel, in the War Council, we have Dr. Guru Prasad sir. He needs no introduction. He is a very senior faculty, and he was one of the first to start with Retina in the northern Karnataka. He was my mentor and Dr. Paras's mentor, and he has taught us wisdom beyond anything. And we are very eager to learn from you, sir. And we have two more War Council who has been there from the start, and they are the backbone of this program. Dr. Devakant and Dr. Kaushik Tripathi, who also needs no introduction in the field, and they are very young and very talented VR surgeons. Today with me in the moderation, I have Dr. Pranav Saluja and Dr. Dipanshu, who are also very backbone of this particular program, and we are very eager to learn from you all. Thank you so much. And also we have one intravitreal talk from Dr. Pallavi. She will be sharing after all the three presentations. And in meanwhile, for all the audience, there will be audience poll as well, where you will be giving points. So every poll has 1 point. And for Dr. Guru Prasad sir, you have, sir, 20 points for each candidate. You can send it to me. And Dr. Devakant and Dr. Kaushik have 10 points each for each candidate. So I think we can start. Dr. Pranav, over to you.
Thank you so much for the introduction. So the first speaker would be Dr. Priyanka. Dr. Priyanka is from Retina Institute of Kashi, ASGI Hospital, Varanasi, and she'll be presenting on long marathon from scrubs to specialist. Dr. Priyanka.
Good evening, sir. Thank you for kind introduction, and thank you, Team UC, for giving me this opportunity. I'll just share my presentation.
मैं समय हूं और आपको समय यात्रा पर लेकर चलता हूं।
Long marathon. Journey from scrubs to specialist. Case 1. Jet injury due to IVTA injection. Case of 46-year-old male. Status post-vitreoretina surgery for vitreous hemorrhage secondary to vasculitis. Silicone oil removal done. IVTA injected leading to jet injury. Removal of IVTA crystals through vent with fluid on. Dispersing crystals with backflash. Preoperative OCT scan showing subfoveal intraretinal cystic spaces. Postoperative OCT scan showing resolution of edema. Subretinal deposition of IVTA crystals highlighted in blue circle. Time to think about mistakes. Blocked cannula. Tip too close to retina. Case 2. Peripapillary PFCL injection. Case of 62-year-old female presenting with full thickness macular hole, pinch trauma leading to HST at posterior pole. PFCL injected in attempt to complete peeling. Subretinal migration of PFCL due to peripapillary arenifil splitting. ILM flap placed to cover FTMH. ILM graft placed over HST. Subretinal PFCL removal with 39 gauge needle. Learning point: direction of PFCL needle should be towards disc. Case 3: peripapillary retinal break while PVD induction. 55-year-old female presenting with left macular hole. Post-operative scan showing both the holes closed under oil. Attempt to PVD induction leading to retinal break. PVD done followed by vitrectomy. Blood clot removed and break margin cauterized. Inverse ILM peeling for macular hole. ILM graft place over break. Laser done around margin.
Post-operative scan showing closure of the hole.
Learning points: correct depth perception and direction of pull towards vitreous cavity. Case 4: double macular hole. 38-year-old female showing presenting with reopening of macular post-operative scan showing break at posterior under oil. Insufficient ILM left for graft after extensive peeling in primary surgery. Amniotic membrane graft taken and cut into 2 pieces. Amniotic membrane graft taken and carefully placed over holes under PFCL. Careful fluid air exchange done. Pre-operative scan showing 2 holes at macula. Post-operative scan showing graft in situ. Think about pinch peel trauma while peeling. Starting a marathon naive, learning from mistakes but kept going. Membrane dissection in case of fibrovascular proliferation due to vein occlusion. Naive fellow after making numerous mistakes. Now segmenting and delaminating her way through sticky membranes. Inverse ILM peeling in case of large full thickness macular hole. PVD induction followed by vitrectomy. Carving her path through each flap. Final saga. Don't overthink during journey. Have patience, persistence, and perseverance till things start falling into place. Finally, word of gratitude. No journey is complete without correct guidance. There is a world of difference between being a surgeon and being a specialist. Thank you for staying those extra hours to bridge that gap for me and for refusing to let me settle for anything less than excellence.
Thank you, everyone.
Pranav, you have to unmute yourself, I think.
Pranav? Pranav?
I think he has some issues. Karthikeya, I think you can take over.
Yeah. So nicely presented, Priyanka. I think there was some glitch in between, but okay. So I'll start the panel discussion from Guru sir. So any comments for the video and anything extra for any other case which you could have done different in these cases, sir?
First of all, I would like to congratulate Dr. Priyanka and the team of Retina Institute of Kashi for being so honestly presenting such complications. It's very rare for people to show complications. They only show their good work, and the complications which they come across are not usually presented. But the way it was managed was really very good. Just a few comments. IVTA, I think you had a nitrogenic break due to the jet effect of IVTA. Is that right?
Yes, sir.
The movement of your videos was so fast, one after another, that I lost track of what was exactly the complication with the IVTA. It was a jet break, isn't it?
Yes, sir.
Break due to
Jet
a
break.
jet.
Yes,
Yeah.
sir.
So I think you brought out the learning points very well. like not being so close to the retina and injecting, checking whether the needle is, the piston is free and freely mobile. I think that's very important to just inject. Maybe even if you waste some IVT, it's okay. IVT is not very expensive. I think these are the two important points that you have to bear in mind. And IVT is not something like OcuBlue or BBG, which you need to inject a little forcefully. Can be injected slowly. I think unless the piston is jammed, there won't be any injury due to IVT. IVT injury is very, very rare. So I think one has to take extra precautions to overcome even that rare complication or not to have such rare complication. The second one
Yes.
was PFCL. I think the PFCL is something that can go under the retina even if it is on the surface of the retina, especially in a silicon-filled eye. And you didn't put silicon oil, you didn't put silicon oil in that patient, I think.
No, no,
You
sir.
just
We
used
closed in silicone oil.
okay. Why did you close with silicon oil?
Because
What was the
they
reason?
were initially, though there was FTMH. Other than that, that posterior pole we caused HST also, so that the flap doesn't move if patient doesn't maintain proper position.
Okay. So anyway, PFCL is something that you can't deal with very well, and it's very difficult to remove subretinal PFCL without causing injury to the retina. If you have a 41 gauge cannula, you can go through the bubble and through the omega sign on the OCT and then remove it. Otherwise, in your third case, you had a PVD induction. The learning point here is that you have to not graze along the retinal surface. You have to keep away from the retinal surface, and always like you do in an ILM peeling, you have to keep on lifting. As you peel, you have to keep on lifting. Similarly, as you peel the PVD, the posterior hyaloid face, you have to keep lifting it. And that is, I think, where you probably had uh, the touch to the retina and the retina tore there. And one thing I noticed was that you stuffed that break with ILM, which is not really required. It doesn't serve any purpose. It might, result in a good-looking, end result at the end of 1 or 2 months, but that doesn't really help in any functionality. So as long as you do laser around the break, it's okay. You should not worry much about stuffing the ILM. And in the process, you're talking about your journey, and you're still young, and in the beginning, you should better not. That is my advice to you, not to do very heroic things. I think the fourth case was about the pinching, right?
Yes, sir. In any
Pinching
primary
that
surgery,
resulted in
pinch
operation.
trauma.
Yeah, I think here we do the trick is to probably pinch in an area of wrinkling, identify an area of wrinkling under high magnification, and pinch it there. Even if it is in the papillomacular bundle, it doesn't matter, but the grip has to be very, very superficial. And can make several attempts to actually pinch the ILM. And even if the wrinkling is at the papillomacular bundle, doesn't really matter as long as you don't touch the retina. I think these are the few things that I wanted to tell in your presentation. Very well presented, and as I said in the beginning, a very honest presentation.
Thank you so much, sir.
Thank you so much, sir, for your comments. Dr. Divakant, sir, Dr. Kaushik, sir, your comments.
Yes, so I think Guru sir has a lot better memory than me. So many cases he was able to recall all the cases. You have shown a lifetime of complications, and as sir said that it was a very honest presentation, and this journey is very important. I see a lot of fellows, a lot of young retina surgeons developing phobias because of certain complications, and take a long time to recover from those. So your presentation is very important in that aspect. And the subretinal PFCL thing that you showed this year at ASRS, if I remember correctly, a similar video won the Red Buckler Award as well. So you can also submit all of your complications to various forums, and hopefully you'll get some recognition there as well. So Very nice cases. I think Guru sir has pointed out the important things in all of those. So just keep doing your surgeries and keep recording these and presenting at TOC forums and across the world as well. And that will work really well for you. So thank you. Over to
Thank you,
Dr.
sir.
Patil. Yeah.
Thank you. Thank you. Guru sir and Dr. Divakant has discussed everything. So main is like you have to check if the cannula is blocked. That is very important, and do not like point at the phobia or at the macula when you are injecting. It has to be on the nasal side. So that was
Yes,
very
sir.
nicely done, and the learning points are also good.
Thank you
Excellent.
so much, sir.
Thank you. And I'll be not giving marks as a judge to Dr. Priyanka because she is from my own institute.
Yes.
Can I make a quick comment?
Yes. Yes.
Yes,
Yes.
ma'am.
So I think in the first case where you have after silicone oil removal, you have injected IVT, right?
Yes, ma'am. Yes,
Because it
ma'am.
was a vitrectomized eye. So you have to
Yes,
be
ma'am.
careful. That was a point you have to take into account. In a vitrectomized eye, you have to be very careful.
Thank you, ma'am.
Thank you so much for your wonderful comments. So we'll move on to the next video, which will be presented by Dr. Kshitij Raizada. He's from Raizada Eye Clinic in Bareilly, and he'll be speaking on the Trojan eye, Marfan emergency with a hidden retinal dystrophy. Dr. Raizada. Dr. Kshitij, you're kindly unmute.
Rich, can you hear us? You're muted actually. You will have to unmute yourself.
Maybe we can have the next speaker. In the meantime, Kshitij can figure this out.
Okay, Shrishti, are you there?
Sir, I'm here, but I'm actually in my car while I'm reaching in 1 minute. Sir, actually,
Right, I think everyone's occupied somewhere. Kshitij, are you ready to go? Is it possible?
The internet is not working.
Or we can have the anti-VEGF presentation.
Yeah, well,
Kshitij, you
because
can
your internet is not
yes,
working.
switch off the video. Then you can just present.
I think we can have Dr. Pallavi stop them, and meanwhile they will.
Yeah. So Dr. Pallavi is here.
Yes. I'll share this.
Yeah. Can you please start the presentation, ma'am? So Dr. Pallavi is from DMC and H from Ludhiana, and she would be speaking on aflibercept in wet AMD case-based insights on our intravitreal armamentarium session.
So I'll be speaking on aflibercept in wet AMD and DME. So this is my disclosure. So my first case is an 84-year-old female. So in the right eye, she had non-neovascular age-related macular degeneration. In the left eye, she had scarred CNVM. So on the regular follow-up, she developed right eye CNVM. Her visual acuity dropped to 636, and we started her on Eylea. So she was given 3 doses of Eylea 4 weeks apart. Her visual acuity improved to 618. So then, because SRF has resolved, and so we kept on observing the patient. So these are the serial OCT scans done at 1 month, 2 month. And at 6 months, she had a reactivation for which 4th dose was given. And after that, after 2 months, a maintenance dose was injected. Her visual acuity improved to 612. So this is the second case, 71-year-old male, right eye neovascular AMD, visual acuity was 636. So started on injection Eylea. This is the first injection. Then at 2nd month, 3rd month, and 4th month, we have injected. These are the serial scans. So after that, we have observed the patient, and So this is a follow-up up till 2 years, and there was no additional injection was given, and the patient maintained well. And from 636, the visual acuity improved to 612. So aflibercept is, as seen in View 1 and View 2 trials, has been shown to be non-inferior to monthly ranibizumab, enabling extended dosing intervals with maintained efficacy. Coming to DME. So this case is 62-year-old male, right eye PDR with vitreous hemorrhage managed with 3 settings PRP, left eye PDR with DME managed with PRP and intravitreal ILIA. So this patient, I selected ILIA because the patient was from Dubai, and the follow-ups was a problem, and could visit only after 4 to 5 months. So these are the scans which were taken like 5 months apart when injection ILIA was given, and the visual acuity improved from 636 to 612 in this patient. Then again, this is a case which shows recalcitrant edema. So 62 years old diabetic patient, status post 7 ranibizumab, 1 Ozurdex implant in the right eye, 4 ILIA were given, and from 660 vision improved to 612. In the left eye, status post 6 ranibizumab, 1 Ozurdex, 3 ILIA were injected, and the visual acuity improved to 6.9 from 624. So as seen in VISTA and VIVID trials, DME, there is enough evidence that aflibercept works really well. And because the mechanism of action of aflibercept is because of its high binding affinity, which is about 100 times that of ranibizumab or bevacizumab, and then broad ligand targeting VEGF-A, VEGF-B, and placental growth factor, which gives it a unique profile, and prolonged durability, which allows extended life, half-life. It's an excellent agent, and it is and the aflibercept strategy works very well when there is persistent fluid which triggers switching. Aflibercept offers benefit for suboptimal responders because it has higher potency, and it overcomes tachyphylaxis and inadequate suppression, which is common because of the lower affinity of the other agents. Then the inflammatory pathways also its target because of the placental growth factor inhibition, and also it has been seen that the resolution of SRF and the PEDs is much better when the switches to the aflibercept. So the key clinical takeaways is because of dual action, dual indication, and proven efficacy, aflibercept has robust phase 3 data in both DME and neovascular AMD, demonstrating superior or non-inferior efficacy versus standard of care. Then extended dosing because of its longer half-life. And then when it is considered as a switch in inadequate responders, it works really well. In patients with DME, it works very well, and glycemic control is often aimed at, and OCT drives treatment decisions should be taken, just not the visual acuity, and safety profile is well established in case of aflibercept. So aflibercept is a cornerstone anti-VEGF therapy for both DME and neovascular AMD with proven efficacy, durability, and a growing real-world evidence base. Thank you.
Thank you so much, ma'am. That was a wonderful presentation. I would love to have some comments from Guru sir and ask him about his experiences with aflibercept, and especially with the advent of biosimilars. What do you think? How will our practice shape up? Guru sir?
Okay. Yeah. I think your first question was about aflibercept itself, that is ILIA, the innovator drug. I have recently started the practice of calling the patient for what I call as an efficacy visit. By that I mean to know whether the drug is really working on the patient or not. There's no point in calling the patient, say, after 2 or 3 loading doses. If you call the patient after 2 months, and at the end of 2 months, if you see that the edema is back, there's no guarantee that there's no proof that the drug has really worked or not. So what I do is I call the patient, say 3 or 4 weeks after the injection. In case of aflibercept, and in case of ranibizumab, I call the patient after 2 or 3 weeks because the durability is less with aflibercept. And if only the effect is good at the end of 3 weeks or 4 weeks, I continue with the same drug. That is my practice, and it has worked very well for me because there are a lot of primary non-responders, meaning patients who don't respond at all, or who respond very minimally, which is not going to be cost effective for the patient in the long run. and therefore I have started this practice. Regarding the use of biosimilars, I feel that I've just started using Anira, which is I must have used it for about 15 patients so far, and I find it equally effective and safe, both efficacy and safety wise. It is as good as Idea, and I think that will be the drug to go for in the long run in the coming days. I don't know about the fate of Idea. I must not say this in this forum, but I certainly feel that the biosimilars in a socioeconomic status of our country is going to definitely benefit the patients compared to Idea.
Thank you so much, sir.
Yeah.
He's from the War Council, Dr. Kaushik, sir.
No, I think the cost is like they are coming with a lower cost version, so that will benefit patients more. And also high dose Eylea will be coming, and we do not have in India, so it will be interesting to see how it works.
Thank you so much. Dr. Divakant, sir.
Pranav, I'll just join back.
Okay.
I think
I
we
think we
can
can move to the next.
Dr. Dipanshu.
We can move to the next speaker. Kshitij has joined back, and
Okay.
Shrishti is also here.
So,
I can present.
Dr. Shrishti can present. I think. Can you share your video?
Yes.
I think we have a technically challenged day today.
Is my video visible?
Yeah.
It is.
Good evening. Today I will be presenting.
Hide that. Yeah.
Today I will present a case of 62-year-old male presented to us with decrease in vision in his right eye since past. 62-year-old male presented to us with a decrease in vision in right eye since past 4 to 5 months. He had previously was operated for cataract surgery for past 8 years. 8 years back in both eye, and he had good gain of vision post surgery. On examination, he had no comorbidities. He was a retired office worker, non-smoker, non-alcoholic. His best critical visual acuity in right eye, hand movement close to face, and left eye was 6/6. This is his fundus photo of his right eye. He had a total retinal detachment with PVR CP12 changes, and he had a single break temporally, single HST break. This is his ancillary reverse chart. This is his left eye, which was normal. So his diagnosis was regular retinal detachment with peripheral retinopathy of CP12, and we planned his band, PPV, endolaser, and silicone oil tamponade. Moving on to surgical video. After putting 240 band, I did a score vitrectomy. I'm using 3D settings at this point, and the maximum cut rate is 10,000 and minimum is 5,000, and vacuum is 50 to 300. So as we can see, the vitreous is actually in sheets, and the core vitreous is in a jelly-like consistency. So I'm trying to remove as much as I can, which is visible to me. Now I put triamcinolone, and with the help of my cutter, I'm trying to I'm also as you can see, I'm trying to remove the posterior vitreous with the help of my cutter initially. And then I have started using the DDMS. So I'm trying to remove as much as possible with the help of DDMS. And then I've switched to my intraocular forceps, and I'm trying to remove with the help of my forceps. The PVR membrane are very thick in this patient, and so there was some difficulty while removing, and I tried removing as much as possible, and then with the help of DDMS, I was able to get more edges, and I removed as much as possible. With the help of forceps, I removed more of the membrane. There were multiple layers of PVR membranes present, so I had to use my forceps multiple times. And then I continued with my peripheral shaving. So after removing all the membranes from the posterior pole, I started doing the peripheral vitrectomy. This was a primary break, so the edges were rolled. So I tried to unroll the edges with the help of DDMS. And after that, I trimmed the HST flap. There were vitreous cases was present, so I had to re-inject triamcinolone and remove as much as peripheral vitreous as possible with the help of DDMS and cutter. There was also some traction along the edges of the break, so I had to remove that as well with the help of my forceps. There was a little break because of the pulling of the retina, which I cauterized. I completed my peripheral vitrectomy. And after that, I have injected BVG dye. I wanted to do ILM peeling, but the ILM came in patches. So only I was able to do only patchy ILM peeling because some of the ILM was already been taken out with the help while I was removing the ERM. So now I started my FX. And I'm draining from the primary break only. After that, I've lasered the break. I did not make a posterior retinotomy. There was some fluid in the posterior pole, but I've assumed that after putting the oil, these fluids mainly go away. So after the laser, I put silicone oil and suture.
Very challenging. Uh, I would request,
I think even Pranav is having. So very nice
Pranav is
case.
having that.
Yeah, Srishti. So I'll start the open. I would like to open the discussion with Dr. Guru sir. Guru sir, what different would you have done and what would you advise for these cases?
Yeah, I would have done it slightly differently, but the way it was managed by Dr. Srishti was also very good. There's no doubt about her surgical expertise, and the way she did it was good. I mean, ultimately, the result was good. I think that is important. In PVR, generally, we are able to do vitrectomy safely because the retina is stiff and it doesn't come wafting into your port. It doesn't come, you know, doesn't get sucked into your port very easily as a mobile retina would. So here, the retina is stiff and therefore it's slightly safer. You did not use PFCL at all in this patient, although the break was not very posterior, I mean, peripheral. It was actually, yeah, even though the break was peripheral, you did not use PFCL and you did not do a posterior retrotomy as well. So I don't know whether you left behind a lot of fluid or not. We would love to see the post-operative images of this patient.
Yes, sir, I have the image.
The post-operative OCT, especially of the macular area, to know the amount of fluid. If it was a small amount of fluid, it's okay. It will get absorbed, as you said. But sometimes not making a posterior retinotomy or not using PFCL at all and trying to do the SRF drainage, endo drainage through the peripheral break can result in substantial amount of subretinal fluid at the posterior pole, which is not seen clinically on the table, but post-operatively you will get surprised by redetachment. That is one thing. In such patients, I think where you had difficulty in removing the membranes and you even ended up with a nitrogenic break, I feel that you should prepare this patient for a resurgery, especially because you have probably not been able to remove all the membranes. It is difficult to say that you removed all the membranes in spite of using repeatedly IVTA and the use of DDMS and maybe the Finesse loop. If you have one, even then the membranes may remain, and these membranes are very, very wily. They can contract post-operatively, especially after silicone removal. They can the apparently invisible membranes can contract and cause a redetachment by lifting off of the break. So I think mental preparation of these patients is important for resurgeries. And the resurgeries at the age of 62, this patient was 62 years of age, I think. Wasn't he? Yeah, I think he was an old patient. So there's no fear of the cortex being left behind, the vitreous cortex being left behind. Vitreoschisis also would not be much in such patients, and therefore you could second time when you do the surgery, you can probably remove all the membranes because they are more mature over time because the silicone oil would also cause some amount of fibrosis of these membranes. So I think these things are important to know in patients in whom membrane surgery is difficult, membrane removal is difficult, membrane removal is incomplete. I think this is what I wanted to tell about this particular patient.
What about the subretinal migration of air, especially in these cases when we are not using PFCL? So
No, subretinal migration of air definitely calls for membrane removal, further membrane removal, because it is an indication of the traction not being relieved fully. So there's nothing of such a event happened in our case.
Yes,
but
yes.
I'm only worried about subretinal fluid, which could have remained. If she has a OCT, macular OCT, or even some mid-peripheral OCT of this patient, it will be nice to know that the retina is attached or not.
I did done the OCT, but I did not include it in my presentation. I have my photo. I'll like to share right now.
Great. So I just want to add one more thing before I hand over to the other panelists. That whenever you have a brain through a peripheral break and you are not very sure of having removed all the subretinal fluid from the posterior pole, you can do like what I do is I do a little overfill, do a paracentesis, remove all the fluid from the antechamber, make the AC flat, and do a little overfill even at the cost of slight raise of IOP, always taking care not to compromise the perfusion of the central retinal artery. And with this overfill, the subretinal fluid, as it gets absorbed, it gets the IOP gets compensated and becomes normal. So this is one practice which I follow. a little overfill, and paracentesis is something which I practice, and I think with that you can get rid of the subretinal fluid, provided it is minimal. If it is very much and causing some balloons near the disc, I think then you have to make a posterior retinotomy or use PFCL again, remove the air, put PFCL again, and then drain again. Yeah.
Sir, actually, I thought that I could have put PFCL. What I could have done different now, I would have done put PFCL at the before my FAX, and after draining the fluid, I could have taken the PFCL out sequentially so that there was no peripheral fluid. But I did not do it. That was my one thing I would have done differently now. But I did leave a little fluid, but it got reabsorbed, and the
Okay.
retina was settled there. But it did form a secondary ERM is there.
Mhm.
I'm planning to remove along with during the silicone oil
File
removal.
removal. Very good. Nicely managed, doctor.
I have the photo if I can share just once. I was not able to show because of lack of time.
I think we'll move on to the
Yeah,
next
it's
topic,
okay.
and
Yeah.
we'll ask you to share the image later on.
Thank you, sir.
Uh, Dr. Kshitij, if you can start your video.
Sure.
Dr. Kshitij will be speaking on the Trojan eye, Marfan emergency with a hidden retinal dystrophy.
A 19-year-old male, known case of Marfan syndrome, presented to our OPD with complaints of pain in his left eye for past 1 day. His left eye BCVA was counting fingers at half meter with an IOP of 52 millimeters of mercury. The left eye had anterior dislocation of the crystalline lens, causing pupillary block. The right eye had superotemporal dislocation of the crystalline lens, with a BCVA of 618 and an IOP of 18 millimeters of mercury. The patient was initiated on systemic and topical anti-glaucoma medications, but to our dismay, he had no relief in pain. After medications failed to bring relief in pain to the patient, the left eye was given a gentle, yet firm massage using a cotton swab. This massage was an attempt to push the lens back in the vitreous cavity, thereby relieving the pupillary block. This attempt turned out to be successful, and the lens dropped back in the vitreous cavity. This simple maneuver was immensely valuable to relieve the pain of the patient, and also buy us time to plan the elective surgery, as patient had a cardiac issue owing to Marfan syndrome. After cardiac clearance, patient was taken up for PPV plus lensectomy plus SFIL. The surgery began with trimming the ciliary zonals. After anterior vitrectomy, we were treated with this spectacular view. This intraoperative still beautifully highlights the fragile and elongated ciliary zonules, characteristically seen in Marfan syndrome. The ciliary zonals were trimmed with the vitrectomy cutter. All of the vitreous adherent to the lens was trimmed, and was followed by lensectomy. The underlying retina was found to have a dystrophy, with pigment clumps marring the central and peripheral retina. Following vitrectomy, a CMT flex SFIOL was implanted in the eye. The patient did well postoperatively, attaining a final BCVA of counting fingers at 3 meter N36, with a well-centered SFIOL. Marfan syndrome with ectopia lentis is common, but its manifestation with pupillary block and retinal dystrophy constitutes a very rare triad, which to our knowledge has not been reported in literature previously. Intraoperative discovery of the retinal dystrophy was a complete revelation to us, as the patient gave no prior history of poor vision in his left eye, and the preoperative clinical assessment precluded a good fundal view, owing to media haze. This is the reason we call it the Trojan eye, because what looked like one enigma carried another within.
Thank you so much, Dr. Kshitij, for that wonderful video. So I would request the War Council to give us comment. Dr. Guru, sir.
Yeah, thank you, Dr. Kshitij, for that nice case. You have managed it the standard way, like anyone else would have managed, except for that causing dislocation, causing something like couching, couching that you did for displacing the lens backwards. That I have never tried in my life, but I will try it henceforth because I've learned something from you today. One thing. Secondly, I want to just tell the juniors here that Sonul's in Marfan syndrome is very, very strong compared. I mean, the Zonus that are gone, but the Zonus that are present are really very strong, and it is very, you just can't pull the lens out in an intercapsular way like you do with the wet test or anything. It's very, very dangerous for the peripheral retina. So never try to do that. This is just an incidental statement that I'm making, nothing to do with the surgery. I had a similar case. In fact, I had a similar case of vitreous hemorrhage in a boy who had poor vision in the other eye, just PLPR, and there was no obvious cause made out because the view was very hazy because of a small pupil and not non-dilating pupil. The eye in question, which had a vitreous hemorrhage, when we operated, intraoperatively, we found a similar picture, and in fact, more dramatic than what your patient showed. Very highly pigmented in the posterior pole. What we diagnosed by looking into the literature as an S-cone dystrophy. I think this also could fit into the S-cone dystrophy, which we diagnosed our patient as. You can also look up and it's an autosomal recessive condition, and therefore seen younger boys and young patients and males. So I think the learning is that in a patient, the general learning is that any patient who has a vitreous hemorrhage and no view, or who has no view of the fundus due to probably a lens like what your patient had, I think you should be prepared for intraoperative surprises. We never know what the posterior pole will be like when you go in. This doesn't happen in every case, but you should be prepared for one. I think that's what I have to say in this patient's case.
We have advised electrophysiological tests and genetic counseling to the patient,
Yeah.
but due to affordability reasons, the patient hasn't opted for them as yet.
Just look up S-cone dystrophy and see if it fits into that.
Also, when in the video, I could see some demarcation line in the dystrophy. It did look like to me like some self-settled retina RD before. Did it was something like that? Because the fundus was not very clear. I could see something like a demarcation line going.
I also agree.
Yeah.
I also agree.
Yeah.
Yeah, it is
Yes.
most likely it is a self-settled RD because other eye you did not say anything. So what did the other eye show?
The other eye is 618 and 6, and the fundus is absolutely normal.
So how do you say this is a retinal dystrophy if it is same, if it is different in one eye, and this is most likely a self-settled RD? Most likely because the demark the area, there is a normal retina superiorly or somewhere, and there is a typical retinal detachment kind of distribution of the pigments. So myopic Marfan syndrome can have retinal detachment which can resolve on their own.
It is a
So
possibility.
yes,
But
no, because other eye doesn't have anything, so this is the only possibility. If other eye had anything, so you could tell that this is retinal dystrophy because you are saying that other eye is normal. So
yeah,
there is retinal dystrophy usually will be bilateral, and specifically if this patient has such a severe disease in this eye, that eye, what you can do is you can do ERG or autofluorescence to see what other eye is, but most likely the clinical diagnosis will go towards spontaneously settled RD.
all right.
And another thing is, in such cases, only if you dilate, just ask the patient to stay supine. If they supine and give mannitol, reduce the IOP, and if you tell them to lie supine, there also it can go back without doing anything.
This is what we had done for the patient. The patient stayed with us in the ward for around 6 hours. But despite administration of mannitol and oral acetazolamide,
No. See, he was supine also. He was supine also. And
he was fine. He
you,
was
you can dilate also. You can dilate the pupil also. In
we
such a
had
case, you can dilate like with tropicamide, and then you can see.
so we had tried all of this, but somehow it did not work in this particular case. And while examining the patient on slit lamp, we felt that the lens was moving slightly behind on applying a gentle pressure. So this is what we tried, and it
No,
somehow worked.
it is a learning for me. But it was very nice that that the pressure reduced and it went back to the vitreous cavity. So very nicely presented. But I'll suggest that do not use retinal dystrophy for this disease eye, because there is a normal retina somewhere and it is not symmetrical. So
All right.
most likely it will be a spontaneously settled retinal detachment.
Because
I think whether the patient recovered vision or not would settle the issue. In a spontaneously rearranged retina, you never get good vision. What was the visual outcome in this patient?
The vision at presentation was counting finger at half meters, and the
No,
final
no, no. After surgery, after your
after
SF5 we put surgery,
the final BCV is counting finger at 3 meters and N36, sir.
which is good, no? I mean, I mean, I'm not refuting the fact that it could be one of the important differential diagnosis is a spontaneously rearranged retina. But at the same time, a spontaneously rearranged retina does not result in a good visual recovery. Usually the vision will be hardly PLPR or maximum CF close to face. If he had 3 meters really, then I think probably something else. I mean, it is one way to settle the issue, to differentiate between, if I'm right, Dr. Kaushik, you can correct me.
I might be wrong, but in my experience, patients who have self-settled RD, they also have some strands, subretinal strands, which are spanning across other parts of the retina. So
Yeah.
apart from demarcation lines, this patient did not have any other subretinal bands. So that's what makes me a little skeptical about the diagnosis of self-settled RD.
But when you are cutting the peripheral vitreous, I could see some pigments also.
Those were primarily because a lot of manipulation had been done, and that is why we couldn't thoroughly examine the fundus in the preoperative phase. Because when we pushed the lens back, there was probably a lot of dispersion from the ciliary zonules, and we couldn't pick up this pattern of the retina in the preoperative phase. And it was only on table that I inquired the patient. Then he said that he has had problems in this eye since the last few years.
Then do share the results of ERG and the
Absolutely. We have advised the patient, and I just hope he turns up for the genetic testing and and electrophysiological testing.
Basically, the 2 points which are very much against is normal other eye, normal retinal finding in the other eye, and there is an area of retina which is not involved in the eye.
Few
And
points
that might explain the visual recovery which you
Yes.
actually had, because the demarcation was passing just from the macula. So some part of the macula was still okay. So that is why
Macula wasn't spared. Macula was totally involved.
totally involved.
Yeah, only the inferior retina is spared. And I haven't shared the OCT in this video, but the OCT shows complete disruption of the photoreceptors through the macula.
So I had also another comment for Dr. Shrishti. So she said that the retina was normal in the other eye. So this her patient did have a very high cupping, like glaucomatous cupping in both eyes, which is very important to know, and it is necessary to get patient tested for glaucoma workup, because and specifically like in such a case who is likely to be one-eyed. So the closed funnel or narrow funnel RD case. And also I'll also use PFCL for that case, because it will demarcate the underlying PVR also, and it will help you remove the membranes. So it is a very helpful uh, adjunct to surgery, and specifically in very like difficult cases of PVR related RD.
So Manjula ji, meanwhile you share the voting link, and we can keep on discussing the and keep it open for everybody.
Okay, doctor.
Yeah. We can continue the discussion.
There's one question I would like to ask Dr. Guru sir and Dr. Kaushik sir. Whether you put band in all the PVR C cases or about or chronic retinal
Yeah,
detachment.
I do. I do. I'm a little conservative. I've gone through all the phases. I've done many cases without band, and over the years, I've learned that band is has an edge in terms of final visual acuity, final visual results, anatomical results at least, in a case of PVR and RD. So I use band in all my cases.
Yes.
A 240 band, it takes me 12 minutes extra, but that's okay. Yeah.
Yes, sir. As Guru sir said, I also would like, if there is a PVR and specifically phakic patients, I'll do for with band only.
So the poll is live. I would ask all the audience to vote for the poll.
I am also supposed to give marks, Dr. Karthike.
Yes, sir. You are supposed to give marks and send it to me.
I will send it by WhatsApp to you.
Yeah, WhatsApp. For each and every. Out of 20.
Right.
Sir, another question, whether you, like in a PVRA fresh RD case, do you laser just the break site, or do you prefer lasering the whole 360 degree?
Can you come again?
Sir, in PVRA cases, like the fresh RD cases, do you prefer lasering the whole retina in the periphery, or just the break site?
Just the break site and suspicious areas. I don't do a 360-degree barrage as many surgeons do, and I don't have anything against them, but I think it is unnecessary. And also, I'm afraid of the laser-induced breaks. There's a tendency when you're doing endo laser to not be able to titrate the intensity of the burn. You end up having heavy burns. You end up having light burns. There's no uniformity in the intensity of the burn, and therefore I prefer not to do that 360-degree laser. I only laser the break and any suspicious areas like flaps or thin retina. That's all I laser. I don't laser the entire retina.
Yes, sir. Thank you so much. Dr. Kaushik.
Specifically, if the break explains your the configuration of a retinal detachment, and if the patient is phakic, then I also do not laser. But in pseudophakics, I have what I have noted is that there are multiple small breaks which might be missed. So specifically during PVD induction, if I see that multiple small, specifically when you are dissecting near the vitreous base, you might be able to see certain small breaks which were not visible during before surgery or during the surgery also. If I find that there is one or more such small breaks at the point where the PVD induction is last, like near the base, then I would like trim all the area and I'll do a 360-degree laser for specifically for pseudophakic patients. But for phakic patients in whom there is a large break and it is the configuration of RD is explained by the break, I would laser the, and it is a fresh RD, I'll just laser the break itself.
Yes. Thank you, sir. Dr. Manjula, Dr. Karthike, if you've got the result, then
Yeah.
you can announce
Doctor,
it.
shall I stop poll, doctor?
Yeah, I think you can stop the poll.
Okay, doctor.
Dr. Devakant, are you there? Okay. So I think, yeah, Guru says masks are there almost. Okay. So we'll announce the winner. Okay. So based on the scoring and also the audience poll, the winner for tonight's session episode is Dr. Priyanka Chanana. Many congratulations. And I wish you all the best for the grand finale, which is going to happen in YOSICon 2026 in New Delhi.
Thank you
Congratulations,
so much,
Priyanka.
sir. Thank you so much, sir. Thank you. Thank you, Karthikeya sir and Paras sir, for all the mentorship and this opportunity also. Team YOSI, thank you so much.
And Kaushik boss.
Thank you, sir.
हाँ and कौशिक सर क्लास में सबसे ज्यादा सर नहीं पढ़ाए
So Pranav, I would like to, you can give the vote of thanks and we can close the today's session. And Guru sir, thank you so
Thank you.
much for coming and sharing the wisdom as always.
Thank you, sir.
I always say that Guru sir is man of very few words, but his one-liners are enough to sail you through, and that's how I sail through my fellowship. He will say only one line in a day, and that one line I kept on writing. So I still have that, and I even gave it to sir in the end. And those words are gem.
Thank you.
Thank you so
Pranav,
much,
you
sir,
can.
for joining. So again, thank you, Dr. Guru, sir, for taking out time for our YOSI Retina Surgical Wars. And we would request you to again join us in a short bit after in the next episode also. Thank you so much for your comments also. Dr. Kaushik sir and Dr. Devakant sir, thank you again for taking out time. And they are our main esteemed war council and they join in all our episodes. And I hope this continues. And again, thank you to the audience for joining and going through the discussion. Thank you so much.
Thank you, sir. Thank you, Guru sir.
Thank
Thanks
you for involving me.
Thank you,
It
sir.
was fun. It was actually enjoyable that we had such good panelists and very good presentations. Thank you, Karthikeya, for involving me.
Thank you, sir.
Thank you, sir.
Sir, it was my honor to present in front of you.
You're most welcome. You did a good job.
Thank you for having us.
I would also like to thank all the panelists and the speakers for their wonderful videos and also Dr. Pallavi for joining. Thank you. We'll end the video.
Yeah.
Manjula ji, you can close the